presidents, vice president, members of council, past presidents, deputy vice chancellor, deans, faculty and fellows, you're all very welcome to this, the 98th Abraham Colles Lecture. It's my great pleasure to invite our president, Professor Laura Vianney, to introduce today's lecturer.
So, good afternoon, colleagues. Abraham Colles was born exactly 250 years ago in Kilkenny. He was appointed Professor of Anatomy, Surgery and Physiology at our Royal College of Surgeons in 1804 and was elected President of our college twice, both in 1802 and 1830. His knowledge of surgical anatomy was immense, and he made many medical and anatomical discoveries, such as the Colles ligament and the Colles fascia. He was the first to describe the spread of breast cancer to the lymph nodes and described his eponymous fracture in 1814. He lived just around the corner in 21 St. Stephen's Green and died there on December the 1st, 1843. The Abraham Colles Annual Lecture was initiated in 1956 in RCSI in his honour. I'm truly delighted today to ask Professor Luke Morris from Memorial Sloan Kettering to give this year's Colles Lecture. Luke is a clinician scientist specialising in head and neck, surgical oncology and cancer research. His clinical practice centres on surgical care for cancers of the head, neck and thyroid. His translation research laboratory studies head and neck and cancer genomics. He is Associate Director of Memorial Sloan Kettering, New York, Immunogenomics, Precision Oncology, Collaborative Research Centre. He has led several multidisciplinary translation research studies and developed new approaches to integrate high-quality clinical data into translational work. He is a frequent visitor to this college and has contributed greatly to our otolaryngology program over the years, and we are truly grateful to him. His lecture title is The Cobra Effect, How COVID-19, Immunology, and Surgical History Can Help Us to Understand Indolent Cancers. You're most welcome, Luke.
Thank you very much. President Vianney, leaders of the RCSI, it's a great honor to be invited to give the Colles Lecture. For me, especially meaningful as a surgeon, as an admirer of the RCSI's history, a proud hibernophile. This is such a great honor for me, and I appreciate you all coming for this talk as well. So, greetings from New York City. I am from Memorial Sloan Kettering, the oldest independent cancer hospital in America, where I'm a member of the Head and Neck Surgery Service. And if you page through the lectures that Colles gave, the thing that is really impressed upon you is that he was truly a polymath. He was an expert and interested in every aspect of human anatomy and physiology. He was interested in everything. And so the goal that I set for myself today was to try to give a talk that he might find interesting. And so you'll let me know if I've succeeded in that. The story begins with something called the Cobra effect. And so around the time that treatise of lectures was published during British colonial rule in India, there was a realization that there were too many cobras on the streets of Delhi. And so in an attempt to get rid of all the cobras, the local colonial administrators said, you know what, we're going to offer a reward or a bounty. And so for every cobra head that you bring in, we'll give you some money. So what would rational, enterprising people do? You'd start breeding cobras, right? So cobra farms sprang up all over Delhi. And years later, when the program ended and all the extra cobras were released back into the streets, there were more cobras at the end than there were at the beginning. And so a basic tenet of economics, when you incentivize something, you get more of it. And there are lots of examples of this in economics. A local example, you might have heard of the cash for ash scandal. Same principle. Well, I'd like to argue that in medicine, something like this happens, but the incentive is even stronger than a financial incentive. It's an incentive that we all feel every day. It's the desire to be a good doctor. It's the desire to be a thorough physician who finds everything that's going on with the person sitting in front of you in the office. And I see this all the time in my clinical practice when I see incidentally found small lesions of the thyroid gland, for example, or small pigmented lesions of the skin that have been biopsied and are melanoma in situ or atypical nevi, or even thin melanomas. The incentive to find disease can lead to the creation of more of it. And when we look for disease, the things that we find are the easiest conditions to find. They meet certain criteria. They tend to be conditions that are highly prevalent, often asymptomatic and just sitting there, often slow growing or not growing at all, and they don't always portend harm. They remind me of the old adage of the drunk guy looking for his keys. And why is he looking for his keys under the lamppost? Because that's where the light's best. When we look for something in a healthy person and turn them into a patient, the things we find are things that meet these criteria. They're not necessarily the things that are going to kill the patient. They're the things that are the easiest to find. And so with screening tests, technology, imaging, blood tests, there is a mismatch between what we want to know and what we can easily detect. And this mismatch, I think, leads to some unintended consequences. I'll ask you this question. Does every human condition need to be found and treated? And we're going to talk about this in relation to cancer. Does diagnosing a disease for early detection really help? Do we find something that indicates danger? And why do some cancers have indolent behavior? Let's start with number one. This is not a talk about COVID-19. You don't need another talk about COVID-19. But this is an experience that every person in this room has had. We've all shared this experience of having a nasal swab done for a PCR test for SARS-CoV-2. And in this study, every patient in blue here had a positive PCR test for the virus. And they also had a positive rapid test, that rapid antigen test you buy at the store and you do at home in 15 minutes. But what about these patients? These patients in yellow are the ones who had a positive PCR test, but the rapid test didn't find the virus. The rapid test was negative. What's going on here? Well, the key is on the y-axis, on the left there. This is the number of cycles of PCR that you have to do, the number of doublings of the cDNA in that little vial that you have to do before you get enough that you can find it. And if you had to do more than 30 doublings of the cDNA, 30 cycles of PCR, there was so little virus there that the rapid test couldn't find it. And the difference between the patient up there and the patient down there is huge. 5 log difference in the number of viral particles present in the back of the nose. But by the PCR test, the more sensitive test, maybe the better test, these patients are all positive. Now there's a difference, and the reason that the authors of this article drew a horizontal line at 30 cycles of PCR is because that's not only the difference between low virus and high virus, it's also the difference between transmissible and not. So what's the better test here? The more sensitive test finds more disease, but is it clinically meaningful? It depends what your question is, I would think. If your question is, can my kid go back to school today? Can I go back to work today? Do you want the more sensitive test or do you want the less sensitive test that tells you if you're contagious or not? Right? You might not want the more sensitive test, especially because we know from other respiratory viruses that asymptomatic carriage of some viral particles in your nose is common. And there are a few of us in this room with SARS-CoV-2 virus sitting in our nose that a PCR test could find. Do we need to know about that? Back in 2021, my hospital started asking us to not get a PCR test for no reason. They said it wasn't necessary, and actually last fall, they shut down PCR testing for employees, perhaps recognizing that the more sensitive test doesn't always give us the best information. An example of the difference between measurable disease and meaningful disease. So this here is the history, the entire history of the COVID-19 pandemic so far in my city, in New York. And you can see we've had a few waves of infection, But here's the other curve, the death curve. And you can see the death curve is dampening with time, and that these two curves, which you would expect for a deadly virus to be connected to one another, are becoming less and less connected to one another. They're becoming uncoupled. So the diagnosis of disease and the occurrence of severe illness have become more and more uncoupled from one another. And when these two curves become uncoupled, we have to ask why. We didn't expect that. Well, there are two reasons. I think instinctively we all understand the disease is different now than it was in 2020 because of immunity and vaccination, and there's less severe illness. But at the same time, testing has changed, and we have more sensitive testing, and this testing is now widely available. So the diagnosis of a disease over time can change in meaning as more sensitive tests detect more indolent disease. And the key to that, and this is where we come back to cancer, is when the two curves are uncoupled, when these two curves aren't moving in the same direction. So let me show you a few examples of that. Number one, thyroid cancer, a big part of my clinical practice. In the United States, we've seen a tripling in the number of papillary thyroid cancers in the last 30 years as we do more ultrasounds and we find more thyroid nodules. In South Korea, where widespread ultrasound use became common, they saw a 15-fold increase in the number of thyroid cancers in a short 15-year period. And yet the death curve, look at the death curve at the bottom there, hasn't changed. Why is this happening? It's the Cobra effect. We're trying to find disease, and if we look, we can find it. More ultrasounds equals more thyroid cancers. Another example from part of my clinical practice, thin melanomas. The incidence of melanoma has skyrocketed in the United States, far more than we can explain by UV exposure. In fact, look at the incidence of melanoma in situ, an unheard of disease in 1975 that now has increased to the same numbers as invasive melanomas. And finding all of those pre-melanomas hasn't actually prevented the development of any invasive melanomas. Why is this happening? It's because we're doing more biopsies. More pigmented lesions are being examined, and it's hard to walk out of the dermatologist's office without at least one of them being biopsied. When you look for more disease, you find more. Another example, breast cancer and prostate cancer. Now here the effect may be a little bit more mixed. There is some evidence that to a small degree these screening tests do save lives, but a far, far, far smaller number than we wish they did, and it's undeniable that the introduction of screening for these two diseases has led to increased number of cases being found without an increased number of lethal cases being found. Another example, non-small cell lung cancer. This is data from the Danish randomized trial of lung cancer screening. And that top line is the screened group, the number of cancers being found in the screened group. That bottom line is the control group. And you can see there's an excess number of cancers being found in people being screened with low-dose CT, and the control group never catches up. So those are cancers that even after 10 years don't show up in the control group. Perhaps cancers that are overdiagnosed. Overdiagnosis is a term that has a very specific meaning in epidemiology, and to get into that, I have to show you this graph. These are the barnyard animals of cancer. So if every cancer starts in the lower left as an abnormal cell, some of them grow very fast. They quickly grow to the point at which they cause symptoms and death, and nothing we can do will fence them in. We can build a fence, but they're birds, and they fly over the fence. So those are the very aggressive cancers. Okay, that's anaplastic thyroid cancer, that's GBM, that's pancreatic cancer. Then we have these slower growing cancers right here, and they're rabbits. So sometimes by the time they cause symptoms or cause death, we're able to fence them in and intercept them. So sometimes we can successfully treat them. But what about these cancers, the very slow growing, the turtles and the snails? They don't need to be fenced in. By the time the patient dies of other causes, they have not even grown to the extent at which they cause symptoms. They cause no harm to patients. There's even another line not on this graph, the dodo bird, the cancers that regress, go extinct. So these lower cancers that don't ever cause harm to a patient are called overdiagnosed because there's no need to find them. They don't need to be found, and treating them is risk without benefit. So does every detection of a cancer indicate danger? It would seem like that's not the case. Well, when a patient comes to your office and they've been given a diagnosis of cancer, they want to understand their survival. And it's not really overall survival that they want to know. They don't want to know their chance of not dying of anything. We could get hit by a bus tomorrow. They want to know their net survival. What did this cancer diagnosis mean for their survival? And we have two statistics that we use. One is disease-specific survival. That's the probability that you're not going to die of this cancer. Another statistic that we don't use as much, but which is intuitively very nice for patients, is relative survival. What's your probability that you're going to live compared to someone who is just like you, except they don't have cancer? Someone matched for age, race, and sex, except they don't have that cancer. What's your survival relative to that person? Is it 90%, 80%, 70%? Well, Andrea Markakis and my research group decided to look at survival in a number of early-stage cancers. So Gleason Group 1 or Gleason 6 prostate cancer, DCIS, and stage 1 melanoma, thyroid, and breast cancer. The dashed lines are disease-specific survival at 10 years, and so you can see those curves are very high. They're close to 100%. So many of these patients are being successfully treated for their cancer. So Andrea then looked at relative survival. How long do these patients live compared to people just like them who just don't have that cancer diagnosis? She saw something crazy. I've never before seen a survival curve that goes up from 100%. But in fact, if you have these early stage cancers, you live longer than your age, sex, and race matched counterpart. How could that be? How does cancer make you live longer? Right, this is crazy. Well, some of it is overdiagnosis. We know from the disease-specific survival that many of these cancers are not destined to cause harm. That's a part of it. But how do they make you live longer? Well, what kind of person gets diagnosed with a stage 1 cancer or stage 0 cancer or Gleason 6 prostate cancer? On average, they are healthier and more health-conscious people who go to the doctor to get checked out, who take care of themselves, who generally live longer than the people who don't. So not every cancer diagnosis portends an earlier death. Some portend a longer life. And as one of my urology colleagues tells his elderly men with prostate cancer, your life prior to diagnosis probably means more for your survival than this cancer diagnosis itself. That is counterintuitive to patients, to doctors, and as a result, we have a whole industry of companies preying on fear and looking to sell whole-body MRIs and blood-based screening tests to patients. These are highly technologically advanced tests. It's not snake oil, but fundamentally, we're looking under the lamppost. We're finding those easy-to-find cancers. We're not finding those lethal, fast-growing, rapid cancers. Okay, so anyway, why do some cancers have this type of behavior? Well, I think a surgical perspective can be very interesting because there's something in oncology that I think is unique about us as surgeons. Of all the oncologic disciplines, surgeons are the doctors who see the entire spectrum of tumors. Benign tumors, the low-risk cancers, and the high-risk cancers. We see them all. And I think this perspective can be helpful. So this is Barney Kreil. His father was George Kreil, the founder of the Cleveland Clinic. And he wrote this article in 1955 in Life magazine. To say that a person has cancer gives as little information about the possible course of disease as to say he has an infection. There are dangerous infections that may be fatal. There are harmless infections that are self-limited or may disappear. The same is true of cancers. Cancer is not a single entity. It is a broad spectrum of diseases related to each other only in name. So he knew about that COVID-19 thing that I was trying to do 70 years ago. He knew about that comparison. He knew more. He knew that some cancers of the thyroid and breast may remain small, localized, and harmless for many years. Many men have prostate cancer, but rarely does it cause trouble. So this was wise. Again, there are no new ideas under the sun. He knew this 70 years before I did. He got some pushback, as you would today. These two individuals, Dr. Blaylock of the Blaylock-Taussig procedure, Dr. Ravden, the chair of surgery at the University of Pennsylvania, said, "This is wrong. The old dictum that the best treatment for cancer is a large operation for a small tumor is still true today." So this was the old guard. This was the Halsted mastectomy, the pelvic exenteration, the heroic operations that we did in the 50s and the 60s. And they said, no, you've got it all wrong. You think these tumors are indolent, but that's because we caught them and removed them when they were small. And Kreil's point is actually the opposite. He says, no, the tumors were small because they were intrinsically indolent. So who's right? We still have this debate today. Are indolent cancers good because they're small, or are they small because they're good? So my research focuses in cancer genetics and cancer immunology, and this is a classic paper from a famous tumor immunologist, Bob Schreiber at WashU in St. Louis. And back in 2007, he described how the immune system, adaptive immunity in mice, could maintain occult cancers in an equilibrium state, a dormant state. And he later developed this very elegant model of immunoediting. So cancers start as normal cells in the upper right, and then they become cancerous for one reason or another. This probably happens every day. Many of them are eliminated by the immune system immediately. A small number of them manage to go into a state of equilibrium, of dormancy. And in that state of dormancy, under constant immune pressure, some of them manage to get edited or adapt to immune pressure and ultimately escape. And those are the cancers on the right that we see as cancers that grow out. This is a very elegant theory that I happen to really like. There's really no direct human evidence of this theory, because when do we take a cancer and then observe it to see what happens? Well, I wondered whether the epidemiologic phenomenon of overdiagnosis could be explained by this immunologic mechanism of equilibrium. So these are the types of cancer that are prone to overdiagnosis: thyroid, melanoma, prostate, ER-positive, HER2-negative breast, non-small cell lung cancer. And as you can see by the percentages here, not every cancer is overdiagnosed. Some of them are overdiagnosed, and we have no way to know when a patient shows up in our clinic whether that cancer has been overdiagnosed or not. Now, we could compare these types of cancer to cancers where overdiagnosis really doesn't happen: esophageal cancer, head and neck squamous cell cancer, pancreas, gastric, triple-negative breast. These are cancers where, I don't care how small it is, it's probably something that you would like out of your body if you have one of these. But we could look at the tumor cells in the microenvironment. We could use RNA sequencing and exome sequencing and T-cell receptor sequencing to try to understand if there are differences as these tumors go from small to big. Okay, so going back to that equilibrium model, if an overdiagnosed tumor is in equilibrium and it's transitioning to the right and it's escaping the immune system, that might happen because of immunosuppressive cells coming in at the bottom. That might happen because of a loss of anti-tumor immune cells leaving the microenvironment. That might come from a loss of HLA and a loss of ability to present tumor antigens to the immune system. So Abi and David and Joris in my lab began looking at data comparing small and large tumors of the overdiagnosed cancer types. And what they found is that the big tumors have much less immune infiltration, much less anti-tumor immunity in the microenvironment. more immunosuppressive cells coming into the microenvironment, a more clonal or more adapted T-cell repertoire, and a loss of HLA or a loss of ability to present foreign antigens to the immune system. And interestingly, these, all signs of immune adaptation, are completely absent from the non-overdiagnosed cancers, as you can see here. So this process is something that we actually can observe in humans when a small, potentially indolent cancer becomes a larger cancer of the same histology. So, overdiagnosis of indolent cancers is common. It's an unintended consequence of our good intentions. We're looking under the lamppost. Immune surveillance probably keeps some of these small tumors in equilibrium, and I think that immune equilibrium probably explains indolent cancer behavior. So all of that is interesting, to me anyway, to hopefully to some of you, and that's great for the Colles lecture in the O'Flanagan Theater. The reality of our patients' experience is different. So when a small thyroid cancer is found, it's high-fiving all around, right? We're proud that we found that little papillary thyroid cancer because we saved a life today. And we're feeling pretty good. And the physician who diagnosed this small, potentially indolent cancer says, I'm just going to send you for a simple surgery to my surgeon, and they'll take care of you. And I don't think it's that clear, because as we all know, there is no such thing as a small operation, especially when you're the person having it, or when you're the person doing it. And the risks of surgery are assumed really most strongly by two people, the patient and the surgeon. And we have a special bond and we have a special obligation to our patients that I think is the great privilege of practicing surgery. It's the opportunity to guide our patients through the decision about whether they should have an operation for something that they've been found to harbor. Well, what's the alternative to surgery? We don't always know which cancers are going to cause trouble. Well, we can do something called active surveillance. For many cancers, we can vigilantly track and observe these cancers, and we can look for signs of growth. At Memorial Sloan Kettering, we offer active surveillance to our patients with small thyroid cancers up to 2 centimeters in size. This is our experience with over 500. And you can see that 80% of these small cancers just sit there. They don't grow. In fact, just as many of them shrink as grow. And for those that do grow, we can then do the identical operation that we would have done on day one and treat them successfully at that point. We didn't make this up. We didn't invent active surveillance. We copied it from the Japanese, who'd been doing it for 20 years before us. And our field copied it from urology, where prostate surgeons have been champions of active surveillance for decades. What's on the horizon? The next cancer that we're investigating active surveillance in is DCIS, with 4 international ongoing clinical trials right now, asking the question, is active surveillance safe and acceptable for women with DCIS? The majority of those trials being led by breast surgical oncologists. I think we as surgeons are natural leaders because of that bond we have with the patient, because of that understanding we have about not just when to operate, but when not to operate. We're natural leaders in helping the field avoid low-value and harmful interventions, and we should embrace this role. Sometimes the right answer is, don't just do something, stand there. I want to thank you all for listening. I'd like to thank my colleagues and my mentors on the head and neck service at Memorial Sloan Kettering, the members of my lab on the lower right, the many friends in Irish head and neck surgery who I've made over the years, including a few that we've been fortunate to train at MSK. I appreciate you all listening. Gorev Mahagut. Thank you very much.
So thank you very much, Professor Morris. That's a truly inspiring lecture. Thank you so much. Now I have the pleasure of giving you a medal. I want to take a few photographs.